I'd like to thank the organizing committee for the kind invitation, especially Professor Karamasis. I hope to provide some food for thought for the very good questions posed. So, why use imaging in calcified lesions? The main reason is that the limitations of angio, with angio missing up to half of calcifications and not being able to provide any information for the subtype, like the arc and the length that can be estimated with both modalities, and the thickness that can be estimated with OCT. So the pros and cons, as we see here, angio performs well only in severe calcifications. IVUS cannot provide thickness due to acoustic shadowing, but it compensates due to its deep tissue penetration, and OCT performs well in most scenarios. So this is a hint to overcome the limitation of IVUS. The presence of reverberations points towards more or less than 0.5 millimeter of thickness. So when we think about image guiding, we all think about the two scoring systems described. We will start with the OCT-based, which was published in 2018. So the parameters described is an arc of more than 180, that's 2 points, thickness of more than maximum thickness more than 0.5, and the length more than 5 millimeters. In this study, lesions that had a score 4 out of 4, that means all the points were suboptimally prepared and expanded with normal means. Speaking about OCT, the OCT is the only modality that can discriminate between eruptive and non-eruptive calcific nodules, with eruptive having worse outcomes despite better acute stent expansion, mainly due to reprotrusion. So let's see also the IVUS-based scoring system. In this system, there is we have 1 point for either calcium arc of more than 270 for more than 5 millimeters, complete circumferential arc regardless of length, presence of calcific nodule, or a vessel of less than 3.5. Many of these parameters, along with reverberations, can also predict slow flow after rotablation. And let's focus now on the consensus papers. Here, the first one is from the European group, which has adopted the scoring systems as previously described. And here in the algorithm, there is an initial provisional predilatation to allow the passage of the catheter. If we have the criteria, either IVUS or OCT, we proceed with calcium-modifying therapies, either atherectomy, rotational orbital, or lithotripsy. They don't define which technique we should use. This is left to the discretion of the operator. And then we reassess if we need any more therapy. So last year we had the consensus document from the other side of the Atlantic. They have merged the two scoring systems. They have mainly used, as we see, the parameters from the IVUS-based one. And we have two modifications for the presence of from the thickness of calcium on OCT. We use minimum thickness instead of maximum thickness, because in this case the minimum thickness could be a break point for a point which we could have fractures of calcium. And they have added also the negative remodeling, which is defined as an EEL at the level of the lesion less than the EEL distal to the lesion, to that of the diameter less than 3.5. In the algorithm proposed, it's more or less the same. I'd like to point out that they have given some guide for which technique to use. So lung diffuse calcium with or without nodular is an indication for atherectomy. Lithotripsy can be effective in a rather broad spectrum of calcifications, especially for deep calcium, and a focal lesion can also respond to specialty balloon like cutting or scoring. Speaking about fractures, here you see the images below a fracture, and on the study, the median thickness of calcium that could be fractured was about 0.45. In this final study, we see a good correlation between OCT and IVUS, and a method for relief for those who don't have imaging at a routine basis, that if you can see it at the angio, it will probably expand well. Thank you.
Thank you, Mario. And now that we know what we have to look for, let's see what Dr. Poulimenos, what Leonidas did.